also ethics at Dana-Farber at Harvard Medical School. Folks have asked if this is going to be recorded, so you can just hear that it is going to be recorded and will be available to be accessed afterward. I'm going to stop sharing my screen and I'm going to turn it over to Marilyn to briefly talk about her experience. Thanks, Marilyn.
Hi, thanks, Dr. Irwin. Thanks, everybody. Thanks for having me. It's a privilege to join this wonderful forum, and thank you for making this happen. I think it's a very important step in the right direction in providing care for individuals with serious mental illness and cancer. Just to give some perspective, since January 2nd, to be specific, of 2012, I started working with individuals with serious mental illness, and during adults specifically, and during these years, I've had to work with quite a few individuals that have gone through cancer treatments, and it's really been a learning experience for me. So I'm hoping that some of the lessons could be helpful in this OpenNotes era. So I think one of the very first thing that comes to mind when working with individuals with serious mental illness and cancer is enlisting their community caregivers. That is a really big thing, because working with these individuals in the community, sometimes we as a community caregivers, we really don't get access to the information that we need to support the patient through their course of cancer treatment. Sometimes it could be pretty frustrating, because you're trying to support your patient who is looking up to you for all the information that they need, and they're asking you all these questions, but you have no answers for them. And there are those situations when you send them to the hospital because they're experiencing a crisis situation, and then say an hour later you're calling for follow-up or for discharge planning, and you have no information. Can you hear me? Okay. So, and everybody seems to tell you, oh, we don't have the release to give you this information. How do we know you are the person you say you are? And it's just a hassle to get any kind of information. So I think right off the bat, it is very important that when we're working with people with serious mental illness and cancer, we should enlist their community provide help, a key part of that whole process. And in terms of the notes themselves, I'll talk about this individual. We're just going to pretend his name is Steven for now. I just like the name Steven. So we're going to pretend his name is Steven. He was diagnosed with metastatic lung cancer, and he had so many questions even before starting treatment, but he couldn't understand anything from his hospital visit appointments, he couldn't understand anything. So I think it was all the technical language that is used in there. It's kind of very hard, especially for individuals who are already experiencing serious mental illness, and we are presenting information to them using technical words. So I think it's very important that we use, when writing notes, we use simple, easy to understand words that the patient will be and their caregivers are able to understand. I'll go back to our patient, Stephen, who every time he asked for us to read anything to him from his appointment, every time there was a technical word, he became really anxious. And at that point, he just shuts down, and everything he says like, does that mean I'm going to die? Does that mean I'm dying soon? How long do I have? So I realized it was important that we write notes in a way that is very easy to understand. I think from our community perspective, from, especially in the group living environment, the way we write notes has also been revised to actually use words that are simple to understand, that anybody that read the notes is able to understand exactly what you're trying to communicate, and to make sure that the note tells a full story from the beginning to the end. So I think it's important to use those words. And we also have to take into consideration the positive aspects of our individuals when writing notes. It is very important that we do not use language that carries a negative connotation. For example, if you write a note saying the patient is refusing treatment, and the patient has access to that note, or their community worker has access to that note and reads it to the patient, it becomes, sometimes that is just setting the patient up to fail, because you've already, without knowing, told them that they have refused treatment and you are not even going to try. So our patient, Stephen, if you ever told him that, oh, do you refuse to go to treatment today? It's like, you said I refuse, and he built a strong wall of defense, and he says, that is what it means, you're trying to send me to the hospital, you're trying to section me. So most of our people with serious mental illness associate the word refuse to Section 12. And say, oh, you think because I refuse, you're going to call the doctor so they can section me. So it already creates a barrier to communication right there. So, but if in the mornings when he did not want to go to treatment, so if we went to him and say, oh, are you choosing not to go to treatment today? So he feels empowered that he is making a decision. So you inform him of the pros and cons of going, and explore with him, why is it he doesn't wish to go to treatment on that particular day. Sometimes he'll tell you, it's just because I'm tired, or it's too early, can we make our appointments later on in the day? And I cannot be thankful and appreciative enough to the Cancer Center, because they work with us. So there are times that last minute we'll call, like, we can't make it, can we have an appointment later on in the afternoon? And they'll be like, okay, we'll try to make it work. Oh, Sarah was an angel from heaven, from the Cancer Center. so it, all the words we use have power. So just try to use words that are positive, that reinforce the idea that the patient has the power to make the decisions, that no decision is being forced on him or her. Because especially for those living in the group home, they already feel like they are restricted, their liberty is somehow infringed upon. They feel like taking their medications is a must. So when it comes to issues of engaging in treatment and dealing with their treatment, they feel empowered when you use the word you're choosing. Are you deciding? Can we brainstorm? And for the last point I want to make is to emphasize the positives. So if you have somebody that is really engaged in treatment, in their notes, you want to highlight those. Often you see notes that say this, that emphasize the negative aspects of the patient. Like, this is a difficult patient to work. Difficult from whose perspective? It's usually from the clinician's perspective. It's just getting to know the patient, to understand that patient, and you realize it's easy to work with that patient once it's a collaborative effort, working with that patient and their community caregivers. So I think those are the 4 key points that have stood out to me throughout these years, like making sure we are writing notes in simple and easy to understand words, making sure we're including the community caregivers so they can support the patient, and avoiding words with negative connotation and emphasizing the positives in the patient.
Marilyn, thank you so much. That was incredibly helpful and clear guidance. Really appreciate your perspective.
Thank you.
You're welcome. And feel free, folks, to ask questions in the chat and we'll respond to them. And with that, I'm going to transition to Steve O'Neill, who's going to pull up his slides.
Thank you very much. Thank you, Kelly and Amy, for having me here. I gotta make sure wait a minute. Oops. I gotta pull up the right slides. Oh, Sorry, this happened before.
That's okay. We all are used to some of the compassion for Zoom. And if while we're loading those, if people have questions, feel free to put them in the chat. I was really struck. People ask me this question a lot. How do you document when someone declines care? And Marilyn's suggestion to say this patient or chooses not to come to treatment today for this reason, I found extremely helpful.
Yes, and I would fully agree with that. I would really endorse that aspect of it. So, so let me just thank you again for having me here. This is an area that is near and dear to my heart, both on the mental health side, where I've practiced for many, many, many decades, and also on the oncology side, where I've had the experience. I've had many family members with cancer, but 2 of my children are cancer survivors, one of whom was in an OpenNotes program, so I could see their notes, which was so helpful in getting clarification on stuff. This is for him as an adult. And the other, when our daughter was as a child, as a 10-year-old, we could not see her notes, and we had all kinds of complications with her care in that. So to me, actually opening up notes has been a passion of mine for many years. And I will say, just as a bit of a backdrop on that, one of the reasons we transitioned at our hospital at Beth Israel Deaconess many years ago to OpenNotes was that we really thought that transparency would be a way to kind of connect more with patients who are fairly untrusting of us in the medical and mental health professions. That there's been so much stuff where patients wonder, whose side are we really on? Are we really doing things for our interests rather than their interests? And you think about some of even the recent allegations from our soon-to-be ex-president, that numbers of COVID cases were being doctored up, so that that because hospitals and doctors were getting greater reimbursement, it sets the stage for people to not trust us. So OpenNotes is really just a vehicle, I think, for enhancing our trust and our accountability to the patients that we serve. So I will walk through a little bit about the experience that we had at the hospital. And I will also say, as backdrop to that, I'm also a bioethicist. And when we started our ethics service many, many years ago, we did it as a service that all consultations that we did would be, we would share our consultation note with not just the patient, but also any of the involved family members, so they would see what we're writing about them. And our legal department was really very aghast at us thinking about doing that. They did not want us to do it. We did it anyway. And the legal department found that we cut down on the number of phone calls to the legal department by better than 50% in the first 2 years. And so that was some evidence that we had well over 25 years ago, that transparency actually really can help the partnership with patients in a variety of settings. And when managed care came to be, one of my colleagues and I made it a policy that all of our patients could automatically we would say to them, if you want to see what we've written at any time, we're glad to share that note. Now that was before, access through, through the computer, but we would pull up our notes via the computer. So some of you know that at Beth Israel, we went online for our medical notes back in 1985. And all of our psychiatric and mental health notes went online in 91. So we've been on that for many years. I'll go through. I have no conflicts to report, by the way. I have to kind of say that. And I'm going to go through these slides fairly quickly in this way. But OpenNotes is simply, we're not selling a product. There's nothing fiduciary about any of this. We're not getting anything for all this. We are simply a movement where we are trying to make patients already have a right to access to their record. And we're just trying to make access much more easy. On the OpenNotes website, we have an OpenNotes, we have a mental health toolkit, we have literature in there, we have suggestions for stuff, we even have a whole section on how to write mental health notes and examples of those notes that I've put out there. And any of that is there for you to plagiarize. You can just have it. It's there for you to take. So, when we started all of this, we're trying to be as open and transparent as possible to everyone. So all OpenNotes is just opening up what we write about patients so that they can see it directly. Okay, so I'm going to talk a little bit about the national experience. We opened up Notes nearly 7 years ago. And for you clinicians, I would encourage you to think about, this is just one more tool in your bag of tricks. And it's kind of has some parallels to, I think, to narrative therapy in particular. So that's kind of where I think of it as analogous. And it's particularly helpful in behavioral health approaches to mental health care. Okay, the OpenNotes itself started on the medical side back in 2010 when we did things, and we wanted to make sure it wasn't, the populations we're serving, where people wouldn't criticize and say, well, that only works in that's a Boston hospital kind of thing that might work there, but it won't work in my part of the country. So we partner with Geisinger Health in Pennsylvania, rural Pennsylvania, and Harborview in Seattle, in the inner city. And we're also doing another study I'll mention at the end, a big thing that we're doing, that we're partnering, in addition to those three, we're partnering with the University of Colorado at this point with a new effort called Our Notes that I'll talk about at the end. So we invited patients to read their notes, and that started with a small cohort before the Cures Act was supposed to have gone into effect November 2nd, the final acts of the Cures Act on November 2nd. It's now been extended to April. So many of you probably know that, but most systems, because the delay got very much last minute, in fact, literally 2 business days before implementation, most systems are simply opening up their notes at this point. And in the partner system, you guys had been constrained really by the advent of Epic, which really kind of hamstrung you guys for the last few years for doing much else. So anyway, so prior to the Cures Act going into effect, we had 53 million patients on OpenNotes in the US. That's kind of a map just of the area, but you can always click on our website and you can see where they are and what systems are in there. Okay. So this Cures Act is going to require direct patient access to their electronic medical record, and really all it is just OpenNotes. And the government calls it, we can't do what's called information blocking. I would say we should be thinking about the language just as Marilyn talked about, framing things in the positive. This is not about information blocking. This is about information sharing, that we want our patients to be more partners. And mental health had been excluded, and I will say we're getting mixed messages from the feds on this, on mental health exclusion. And I've seen some communications, particularly from the OCHIN group, which oversees EPIC implementation, that they're saying in behavioral health notes do need to be opened up. And that's our assumption, is that they will be opened up even if sooner or later, no matter how you cut it. And so I think it's safer for us to assume mental health notes are being opened up along with the medical surgical side. Okay, our 3 questions that we've always posed when we do research is, would OpenNotes help patients to become more engaged in their care? Would OpenNotes be the straw that breaks the therapist or the clinician's back? And after 1 year, would patients and their therapists want to continue? So those have been our questions. And the same thing was posed, we've been posing on the medical side. Okay, so here's our experience. We opened up in psychiatry, in 2014, and in social work. Most of the therapy at Beth Israel is done by the social behavioral health clinicians in social work, and psychiatry was doing a lot of psychopharm, with the exception of the residents, of course, who have to do, as part of the training, they need to do therapy as well. So there was a mixed thing, but we were only just the attendings took part in this initially. Now, basically, bottom line is, all staff in our department, our social work department and psychiatry department, are fully opened up, and we have been opened up now for nearly 7 years. So, but when we started with some staff doing an opt-in model, choosing some patients that they might want to do, but most of our staff chose to just fully open up all their panel of patients. And I will mention, this is one of the questions, the notes, when we do notes, and I've only heard of one system in the country that's done them retroactively. All systems generally do it from a set date. It's going forward, not back. Because when I think about some of what we wrote many years ago, some of the detailed stuff, I'd be a little embarrassed by some of that. So anyway, so this is where we have, and we have actually, it's probably closer to 4,000 patients currently participating in open therapy notes at Beth Israel at this juncture. So common concerns that all of you will have about OpenNotes in mental health. So is number 1, it's going to cause harm. right? Most clinicians are really worried about our obligations to do, make sure we're doing our best by patients, principles of beneficence, and we worry about non-maleficence, right? Is this going to cause some harm? And so many systems don't open up mental health notes. They open up the medical side, but they've not opened up the mental health side. And yet, when you look to our medical colleagues, I would encourage you to think about the kind of care that goes on in primary care, where, as an example, and also in oncology, where the details are really very, there's a lot of graphic detail in there. So most primary care physicians will be doing graphic details about someone's alcohol use or drug use or their sexual activity and things like that. So it's, what they've been putting in, they've been dealing with that for years. And they've been documenting about our patients because, a huge percentage of the mental health care in this country is handled by physicians, by primary care physicians and oncologists as well. And so in some ways, they're already doing that, and they're kind of leading the charge for us when you look at the notes and stuff. So that's the big question is this going to cause harm? Okay. Some of the fears that we had in our system, and this has been largely replicated, particularly the number of studies from the VA. The VA hospital opened up all of their ambulatory and inpatient psychiatry unit notes back in 2014 as well. It's not too long, just several months after we opened up ours, they opened up theirs, and they've been doing that. So that's across the country, and they've got some really good literature out there. So there was a worry that this is going to increase the work burden. I'm going to have to think about doing my notes in a more timely manner. Although as a manager, I will say getting notes in a more timely manner has been a godsend. So my delinquent staff have gotten much better at getting their notes in. That's been my experience. So for me, in that way, it's always been very, very helpful. So there was also worry by all of my staff that, they're about misunderstanding my patients. I'm concerned they're going to misunderstand information in the notes. On the other hand, I'm hopeful that the open notes may actually enhance the therapy process and promote greater communication and understanding on both sides. And I've got several articles that have been published about some of this, a number of which came out this year and last year. And all of the literature we have is in our website as well, so you can access that at any time. So my staff were worried about relanguaging notes. Are we going to have to rewrite the notes? Are we going to have to do things? Now, along with what Marilyn mentioned, it's a good thing to kind of think about the use of plain language. So that is really helpful. To think about that. And what we found is that for our staff, we did not have to relanguage our notes because we also have professional obligations to do certain kinds of documentation about things. And a lot of patients wonder about the redundancy of some of our notes. Why do I put down a mental status exam in every single one of my notes? Why do I do something about a lethality assessment, in terms of their suicidality or homicidality or whatever it might be? So, but those are professional requirements. And usually when we explain that to patients, that really helps a lot. And I would say the only change that most of the staff have done is they have used a lot more quotations from their patients. And actually, patients really like that when you put it in a direct quote, because you're taking what they have said. And so that really helps them to know you've heard them in that way. But to Marilyn's point about, kind of the use of plain language, there are some things that are really helpful for us to kind of think about putting in plain language. So oftentimes I would use the word, affect dysregulation or mood dysregulation. And so I simply change some of the language about that, about the patient being upset or whatever it might be that I'm trying to cite. What we found was that it made our notes a little bit shorter and briefer and in fact more understandable. And actually patients like that, and actually my staff liked it. When we did a study on the amount of time that it took to do the notes, it took less time ultimately for once they were in open notes to do this. And they felt their notes were actually better in that way. There is a worry about, will patients get angry about certain content that they see? Patients that tend to be angry, will they get angry? And what I would say is that, and I'll talk about this a little later, but mostly patients are looking for a concordance between what we've said in the office and what's written in the note. They don't want to feel ambushed. right? So you can think about, an oncology patient, reading a note and saying, wait a minute, they didn't talk to me about this, and oh my goodness, right? So those are some of the fears that you're going to have, but that's really where the transparency is important about thinking about what are we putting in there or not. So, and across the country, we thought that we would hear all kinds of bad things happening. We have not heard that. And there's one health system out in the West that has deemed this the big quiet because they've not seen any of the stuff that they feared would happen. It's just not materialized. And that's been our experience now after 7 years. So. Right, will we have to change our notes? Possibly double chart and important information will be lost. And we have found that that is not happening. We do not have to double chart. Now, I will say sometimes, particularly on inpatient services, there's a lot of communication that goes through the chart that really is probably better intended through another means of communication, such as an email. So you do have to think about, but that was already true. The patient can have access to that record after a hospitalization or when they request their chart on the ambulatory side or whatever it might be. So it's important to kind of think about what we're putting in there because patients still have access to that. And really is the intent to who's it to communicate to. So I do think that it makes a difference in thinking about who we're importing that information to. Okay. So the relanguaging, okay, that we have all that. Patients with severe mental illness, especially psychosis and paranoia, will they flee? And I will say, when I started doing this, about 30 years ago, when managed care first came on the scene, actually closer to 40 years, I thought my paranoid patients would leave. And what they found was that they said to me, they asked me, could I see my last note? And I would pull it up. They settled down. I thought they might leave. They might not like what I'd written and stuff or be upset by it, and they flee. Most of them actually stuck and they've settled in. So I found it to be really helpful in that way. And this notion about, it's one thing to tell them in session where you're thinking they're having paranoid thoughts and another for them to read it at home alone. Most patients that are having paranoid thoughts know that we may view their perspective differently. And the way we think about charting something like that is I simply write the patient's perspective and then I write that I have a different perspective. And my perspective is maybe that they're paranoid, maybe they're psychotic, whatever it might be. I don't necessarily change the language of what I would normally do, but patients find that respectful when I've written both sides in that regard. Okay. For when we started, we did an FAQs that we developed for both patients, for the providers, and also for the support staff, and particularly the front desk staff who get bombarded with questions that they don't want to worry their clinicians about when they're seeing them. So a lot of times it's really important to help educate our support staff because they are sometimes the bulwark of support what gets us through and gets patients through in that way. So, and we did have to anticipate what are the reactions and feedback from patients and colleagues. And then the staff thought about, okay, we're developing a thesaurus for altering language. And again, as I mentioned, that work group disbanded after a couple months. They found they did not need to develop a thesaurus or change things. They simply changed language to plain language, or if it was something they needed in there professionally, they explained it to patients, and then that really took care of it. Okay, what did we find? Patients were pleased. They want the notes, they read them, they're not scared, they share them, and they report important benefits. Okay. In our studies, and this has been replicated in a number of sites, and we have some other studies going on, a big one in Toronto, where we have currently 1,000 inpatient mental health and substance abuse beds, and 1,100 outpatient therapists are participating in a big study up there. And 90% of patients agree it's a good idea to open up notes. 85% or better want to continue. And few patients said that they felt judged, worried, or offended. And we didn't do a study in this, but most of the patients that felt judged, worried, or offended were oftentimes more in the beginning stage of therapy when you have a therapeutic alliance that's just developing and there's some ambivalence about therapy. A lot of that gets worked through and can be talked through. And what about the 10% that said it wasn't a good idea? It wasn't that any of them said it was a bad idea. They didn't care about it one way or another. They felt like they had a good relationship with their therapist. And so if they saw the notes, it was great, but if they didn't, that was okay too. So that's kind of what we found in that way. There's almost no resistance to it from the patient community. The resistance is largely from the therapist community. Adverse effects, most of what patients worry about, what we've learned from them, is that they're more worried about who has access to the notes. So if somebody is more peripheral in their care, so somebody that's treated in your oncology service, your patients are generally going to feel fine about the oncologist and the primary care physician having access to the note, their community health worker having access to the note, but they may not want to have someone that is more peripheral, their ophthalmologist, their podiatrist, other folks seeing their therapy notes. But generally, in our system, the notes are open to anybody that's in there. And, when we explain that to patients, they're okay about it. They don't like it. They'd like to control the circle of who has it. And as I mentioned, they're mostly looking for concordance between what is said in the session and what's written in the note. Okay. One thing that was an interesting finding that we have, that I haven't written about this in any of the papers that we published on it, is that our patients in our hospital never mention to their therapist about having read their notes. And what we found when I looked at that, I should have probably written something about this, but is that the therapists were all waiting for the patients to bring it up, and the patients were all waiting for the clinicians to bring it up. And so neither one was bringing it up, which was surprising. So I mention that because I think it's a way to we as clinicians should be more active with asking, what did you think of your last note and how was that? And, did you have any questions from that kind of thing? And I will say in the mental health field, particularly for ongoing therapy, the note reading rate drops off a lot differently than it does on the medical side because our notes tend to be pretty redundant when you look at them. So that's one thing that we did find. Okay, privacy and confidentiality. 18% of patients on the mental health side share their notes with others, mostly family. If you compare that on the medical side, 20 to 42% of notes on the medical side are shared with somebody. So that's a little bit different. So people are a little bit more circumspect about who they share that with. But having access to it, as Marilyn mentioned, having a community health worker or the care providers, some family members taking care of somebody, if they can see what's in the note and the patient can share that with it, it is so clarifying, not just for the patient, but also for others that are involved with their care. Okay. And every system worries about the nightmare patient, right? And I know you guys have them there. I hear about some of them sometimes, particularly on some of the services that I interface with, including your Optimum Care Committee group. So anyway, so every system I've worked with always has nightmare patients. They worry about the labor intensity of those patients. And I think it's really an index for a contagion for staff angst. They worry that those patients will rev up. We do not generally find that that's true. And I will say, I had a couple labor-intensive patients that one of whom was calling our practice multiple times a day because she gets so anxious and can't hang on to anything. And so I kept reminding her, would you look at your note? Would you look at your note? Just take a look at your note. And she finally did that. And then I have a number of patients that used to do this. They would print out their note from the last session and put it on the refrigerator or someplace where they'd see it as a reminder of what they're supposed to be working on. And it's a way to kind of carry the therapy forward. And for that labor-intensive patient, it did get her to stop calling the practice as often because the answers that you were looking for were oftentimes right in the notes. So it really did help in that regard. But that's, again, that's largely anecdotal. We have not done a study on that in that way. Okay, clinical benefits. Better than 50% of our patients felt more in control of their care. Better than 50% better at self-care. 40%, better than 40% felt better remembering when working on what they're working on in therapy. And better than 40% felt more engaged in their therapy. Now, that doesn't mean the other 60% didn't feel engaged. It just means that, they may already feel well engaged, but we're talking about 40% felt it strengthened their engagement. So, and better than 50% felt better able to trust their therapist. Okay. So bottom line, better than 80% want to continue. Better than 60% said it would directly affect their future choice of a therapist if they were choosing between a therapist that was in OpenNotes and one that was not. And this has also been replicated on the medical side, that they would choose the OpenNotes clinician. So, and not one therapist or patient has asked to stop, and all have joined now. Lessons learned from this, and this is particularly important, I think, in the oncology world, is what we call the 70-30 rule. when clinicians are delivering bad news to a patient, it is expected that the patient will not remember any more than 30% of that bad news. So think about that in an oncology service when you're delivering a diagnosis. And I will tell you, the first time one of my kids was diagnosed with cancer, I think my wife, who also works in healthcare as a hospital administrator, she and I were probably in about 5 conversations with different clinicians before we could hear anything about it. And I remember this, and I teach in informed consent, right? So I couldn't hear anything until someone said that they could save her life, and that was the first time I could start to hear anything. So those are important things, because if I look at notes, I wouldn't remember anything, right? So if I go back and clarify it, it's really important. Now the 70 part is when you're going for a well visit, your annual physical, and hopefully it's a well visit. Patients generally then remember 70 to 80% of what goes on in the session. But that still means you miss 20 to 30%. So going back and seeing the note really helps to clarify things. And for those in the oncology world, where you're inundated and overwhelmed by information, and you can't remember, and all of your friends and loved ones are asking you questions and peppering you with stuff, if you can go pull up the note and remind yourself or clarify or look at that with them, that really is helpful in that way. So and if we think about that on the medical side, that is certainly true on the mental health side, where patients may be anxious or depressed or not able to hear things in that way. Stigma, I wanted to mention this, particularly because of all the efforts that Kelly and your group and all the folks here are doing to try to help destigmatize mental health. My view is that when we have segregated the opening up of mental health notes separate from medical notes, I think we unwittingly contribute to in reinforcing stigma that our patients can't handle it, when in fact the vast majority of patients can handle seeing their notes, and in fact actually are helped by it a great deal. So I think we will do better if we mainstream this, and that would be one lesson that I think we've been learning from all of this. Don't separate out the mental health notes from the medical notes in that way. Okay, and the other fear that's underneath this that we haven't again studied so much, but I hear about it both from my own staff and from many other folks, is that professionals oftentimes we worry about looking foolish or incompetent, particularly if we're wrong about something and we put down diagnostic impressions or whatever it might be. So we do worry about that. So, and then I'm going to just mention active and passive utilizers. So I mentioned before about being more active with our patients, about asking them about, if they look at their notes and if they don't. Now, I will say, I certainly have had patients that didn't look at their notes. I can think of one who was severely and profoundly depressed, that he didn't look at his first note for about 2.5 years in. The notes were available all that time, but he didn't look at them because he was absolutely convinced that what he would see there would be reinforced that he was the worst possible person on the face of the planet. And that would reinforce his fears. When he finally looked at his note, which he says he looked at accidentally when he was looking for a medical note, he found that the note kind of reinforced about how resilient he was and how strong he was. And this is for someone with profound deficits as well. And it's kind of what Berlin mentioned before about emphasizing the positives in there. He found that very helpful. He then was able to start to look at notes periodically. And I would say it was probably every 6 months from then he would look at a note, but not much more often than that. I had another patient that was in a group therapy that she would look at her notes and she would decompensate after looking at her notes because she viewed that what was written there was just an indictment of how horrible she was as a person. This group asked her to bring, she would share her notes in a session. She brought her notes into the session and shared that with them. And the group helped her to see that, in fact, actually, her notes didn't say anything like what she was interpreting. It was totally different. And in fact, emphasized, again, her strengths. And she was, again, somebody who, again, always filtered things through a negative lens. And the group advised her to only look at her notes before she came to a therapy session, either a group or individual therapist, or if she had supports around. After a couple of years of doing that, working with her along that line, she can read her notes with no problem at all now. And to me, it was a little bit of a way to measure her progress within therapy. But the active and passive utilizers, it's important to kind of think about how we utilize this as a tool. And here's one of the reasons I also say it. So in our system, if in advance, 2 to 3 weeks in advance of an upcoming appointment, a patient gets a notice that says, you have an upcoming appointment with so-and-so, would you like to see your note from your last session, last appointment? So then this assumes there's an interval history there, obviously. And so in Geisinger, when they were doing it, it was a 1-year study when we started this. And so at the 1-year job, they had their notifications stopped, just they had forgotten to keep it on. And so they stopped the notifications, and the read rate for their notes went from 60%, dropped down into around 15%. Where you can see the blue line there is Beth Israel's read rate, which continued around 55%, somewhere on there for average. So it's important patients get, that we think about being active in this and making the systems easily accessible for them and reminding them that the notes are in there for them to see in that way. A couple of the points, 99% of people are likely to feel the same or better about their doctor after reading just one note. That's from a study that a group of some of my colleagues did in the OpenNotes program. This is particularly helpful on psychopharm and with oncology services. 60 to 78% of patients have described taking their medications. They do better with it because they understand why they're taking it more. So that's, I think, has really important implications. We never expected to have that high a number, and that's been replicated now in a number of studies. Okay, our notes. We're also moving to our notes, where we're actually having patients document in their medical record. This becomes a permanent part of the record. 2 questions, and the 2 questions are, and think about this in an oncology service, is, has anything happened to you since your last appointment? And now again, that will assume there's an interval history. We limit the number of characters, so our obsessive patients can't write 50-page tomes, but you've got a limited characters of 350 characters. And then the second question is there anything you want to make sure you would you ask or address in the upcoming session? And because patients tell us all the time that they get to these our appointments with us, and when they're so chock full and the agenda is so rich, and that they don't have time to ask the questions, or they forget it because they've got so many other things on their mind. So if patients write that down, so we're starting that, and we started a pilot study out at UCLA that we have some published findings from 2 years ago, and now we're starting that as in a number of centers, the ones I mentioned before. So we're starting that, but I'm also trying to think about that on the mental health side, how that might help some of our patients, and particularly for patients where there is a little bit more of an interval history there. So what this is largely about is really about communication, engagement, and trust, and the best possible outcomes. And I will stop there and tackle questions. Let me just tackle one question that came up that I saw from Kelly that sent beforehand about documentation and how to document. So I would recommend, again, using a lot of quotes. I do that. When I have differences of opinion, I can think of a delusional patient that I had that believed that he literally moved from his household a couple of times because he was afraid the fire alarm, the smoke detectors were bugged with cameras and what have you. And he had a very limited delusion and is a very high functioning person on the outside. So as long as I documented his perspective, but I also documented my own, then he was fine about that. And that's generally what we find with most patients. And I would say, again, the plain language is really important. And I think it's really documenting your clinical assessment. On the medical side, I'll just tell you one thing that we found that's also true on the mental health side is patients that are large persons. We use the term obese and we use the term morbidly obese, and that's been the one that's been probably the most offensive to patients when they see that. And yet reimbursement, when you don't put that in as an ICD-9 code, it affects the reimbursement for it. So when a medical provider writes that in their note, it helps enhance they only get reimbursed when those terms are in there. And so it does make a difference in that. When we explain that to patients, they're okay about it. It still is offensive language, quite frankly, and it's much easier to think about documenting a BMI or just saying the person's a large person because patients know that. So it does, and yet I also say there's been a few patients when they've seen that have had flights to health, So sometimes it can be helpful, and then other times it really has the opposite effect, and patients get withdrawn and really get a bit depressed when they see that. So it's a little bit, with not ambushing a patient with the language and talking with them about that when they have questions and encouraging them. So that's what I would say. I'm going to stop there. So.
Thank you so much, Steve. It was so helpful. And I'd like to thank all the participants who sent in such really good questions during the talk and ahead of time. One of the questions that's come up a lot is about safety. If there are concerns about abuse or neglect, particularly with older adults and our pediatric AYA population, what are your suggestions about documenting to preserve people's safety?
Right, that's a great question. And so what I would say, there's a couple different areas. So particularly in domestic violence in particular, I mean, one of the reasons we generally, all health systems generally have a domestic violence program, and we don't bill for those services because if we bill for the service, it may flag for the perpetrator of the abuse that person's receiving services. So if they're the subscriber, they will get a notification potentially that someone has accessed services. It doesn't say what happened in the services, but they've gone to Mass General to one of the programs and they're seeing somebody, and then they may ask about that. So generally that's why domestic violence programs are usually not charging and don't use insurance, because they don't want to increase the danger. Now, it's also true that in any practice, all of us find that we have patients who are dealing with safety issues across the board. And so then the question is, how do you work with that patient to make sure that you limit the access to those notes from the perpetrator? All right, and so like in fact, I was on a conference call this morning with our domestic violence program about this very thing. And what we do is in our system, we can do what's called monitor the note or segregate it from the chart. And I believe in the EPIC system, there's a way to sequester the note and segregate that note if in fact it might be harmful to the patient. So that you can pull it back so that no one has access to it outside of the system itself. And even within the system, you have to do a lot of overrides to get access to that note. So usually, that's what we do to kind of protect patients in that regard. And so, and there is kind of the notion of, for instance, in adolescence, what comes up in work with adolescents, the most systems have graded emancipation of the note from emancipated minors. So a 12-year-old, most systems start that the 12-year-old and up, they have access to who decides can see their note itself. But the parents may still have access to the appointment schedule, et cetera, because you don't want to have a chilling effect of those patients talking to their clinician, their therapist, or their physician about their drug use or sexual activity or whatever. You don't want to have a chilling effect so they don't seek care. So that's part of what it is. But a lot of times it's working with those patients. And if we think about the frail elder population, working with them to, if they open up their notes or domestic violence victim, to only open up the notes when they're absolutely secure and safe to do so. They're not going to leave, you walk away to go to the bathroom, they're not going to leave the monitor on or the chart on in some way, where there's some access, and they, we have to safeguard it. So that does take more active involvement on the part of the clinician in that way, and engagement with our patient to think through when it is that they should be open or not. So.
Yeah, I think that's really important. Building off that, I think one of the other questions is kind of like, when would you sequester a note or block a note? What would constitute that kind of clear immediate danger or risk of harm? And I think domestic violence is a really good example. I think that, sometimes we worry that a patient would be so upset by what we document and that they are at risk, whether they have suicidal ideation or potentially have, be expressing threats about harming other people. We worry that the content of our note might push someone in that way. How do you manage assessing whether to block a note?
That's another really good question. And there is a really good study that the VA did, because the VA population, they found that a lot of their veterans are dealing with PTSD. And so what they found was there was an escalation in the anxiety level of patients with PTSD when they read their notes. And so the change they did at the VA is that they got the clinicians to talk with their patients about the fact that if they read this, it may feel like a re-traumatization, because when you look at psychiatric notes, particularly when you're dealing with someone with trauma, most clinicians tend to over-document they write down the lurid details of what happened to the person, because they oftentimes know that could go to court, and they would like to kind of have the patient feel they're backing them and they heard them. So they write a lot of detail about that. But when the patient then reads that, it sometimes re-traumatizes them because it's a recapitulation of the experience. So what the VA did was they simply started telling patients, don't read the note until you're coming to therapy or you have enough supports, or remind yourself that in fact you could get re-traumatized. So there is that's the one area that we have seen where there's been a little bit of a side effect in that regard. But again, it's been worked with pretty well. And I will say, by the way, the VA in their system, and we have a link with this in our OpenNotes program, they have training modules that they do for all of their mental health staff. And they have really good training that Steve Dobsha and his group have put together, and those models are there for anybody to see. They've been sharing that for how they do training and stuff on all of these kinds of aspects, particularly around the PTSD issue, because that's a recurring issue within their services. So.
Steve, one of my social work colleagues in the inpatient world asked an interesting question about how, or if you have any data on how patients have responded to notes written by a social worker they may have only met once or twice. Sometimes we meet people in the inpatient setting very briefly. There really isn't a chance to make that bond. And so I wondered if what that had been like for some of your inpatient colleagues.
So I will say the inpatient colleagues at Beth Israel, we don't have the experience. They're just going live on the inpatient side now. So when the staff that we had, these are only for billed for services. So all of the 25 staff that I had over there, that was for billed for services that we were opening up. So it's only that's what that was limited to. But I can tell you kind of anecdotally, more from around the country with some of the services that have opened up some of those notes, particularly in the social work field in that way, there's no difference. Patients generally know that, they've met somebody only once or twice. They know that the social work may be doing detective work in a variety of areas, getting collateral information from all over and putting together a note. So that's important. I think what's tricky is having patients not feel ambushed if they to see information that a clinician got from other sources, where the source says to them, well, here, I'm going to share this with you, but don't tell them I said anything about that, right? Same thing with if I have a spouse or a partner, or someone who calls me and says, let me tell you about you're going to see my loved one for their drinking or drugging or whatever it might be, but don't tell them I called. Well, I don't want to hear it then, because if I can't use it and identify, it puts me in a clinical bind, I'm supposed to be there for the client. So it's really, that is important to kind of clarify those aspects, that it's, where did we get that from? But so I would say that it doesn't make much of a difference, I think, from what we're seeing and what we understand so far. But again, not well studied in terms of just the once or twice. I mean, I can say from my experience in ethics, as associate director of ethics at the hospital, that I oftentimes met patients only once or twice, and that was it, and was doing a long consult note that they would see. Ideally, I would actually show them a draft of my note in advance to have them kind of make sure I captured their perspective accurately. So I would actually do that, but a lot of times they then see the note. I've met them only once, and it's these are long, detailed notes, and I'd give them the note, and we generally had very good feedback. They appreciated it. They might not like what was said there, but they appreciated it in that way. So,
going back to the questions, some folks have asked about whether patients find it distressing to have fewer technical terms and strategies to make sure you're not watering down your documentation while trying to communicate clearly.
Yeah, I think the watering down, I think we've not seen that people have needed to do it. It's really been fully there. I will say one thing is that our psychological testing service, they don't sign their notes, so they're not accessible to the patient till after they've seen the patient. They tend to, because those when you're doing personality profiles or you're doing any kind of an exam along that line, they really want to have the discussion with the patient about what the findings were. They don't want to have the patient read it. And it's why that there's an embargo, like in oncology services. If you've got a person going through an oncology workup on the labs, most systems will delay the labs for 3 days or so, sometimes a little bit longer, before the patient can see it, so that the clinician has an opportunity to find, oh my gosh, they've got X, Y, and Z going on, and I've got to make a game plan. So they want to make a plan rather than having some anxious patient understandably call them when they have not seen or known about what the results were. So there are ways to put embargoes on some things to delay when it comes out. And that's generally what a lot of systems do. And that is certainly true in the Epic system, that you guys can put embargoes on when those things need to be in place.
Whether that be for radiology or pathology.
Yeah, exactly.
And I think that some of that is still getting figured out. So we can kind of get back to you about the specific embargoes that are in place at Mass General. But I think a really important question. One other question was use of the language patient denies. I'd offered some thoughts in the chat, but Steve, do you have other thoughts about people's reaction to that documentation? Patient denies this to be true, or patient?
Yeah, so it's true. Marilyn was totally right. Patient denies has all kinds of pejorative language because, sometimes that patient, they oftentimes tell us what they think we want to hear. Yes, I'm coming to my next appointment, but now they're out in the real world and they're faced with, oh my gosh, well, I've got to go find a job, or I've got to feed my kids, or I've got a sick kid, or I've got whatever it is that's out there that they've got to deal with. There's a lot of our patients live in the moment. And so sometimes that's the way I might document it, is that the patient is conflicted with other needs in some other way, or is having trouble organizing themselves in some way. But I wouldn't, the language does matter a lot. I mean, if there's anything we've learned in the last 4 years, language matters, right? So, it's really crucial, and our patients will give us that feedback. And I think it is important to kind of think that denies is really a problem. That's us, not them. They deny. But putting it in that their perspective is different from ours, or my perspective differs, or whatever. That can be helpful in that regard. So.
I know we're almost approaching 1 o'clock.
Okay.
One important question was do you inform patients about them being able to see their notes? And clearly from your presentation, it sounds like you really advocate for that. Do you have guidance for clinicians, like when their patient comes in for a first visit, to talk about the shift when a person comes back, to let them know that this is going to be a new way of interacting?
Yes, I would totally encourage you to do that. And one of the things we found when we had some places around the country that said they'd open up their notes, and then we found out from patients when we were surveying them in other systems that they made it so difficult that they had almost no patients looking at their notes because they put in so many barriers. So, I think it's important to let patients know, and we're really communicating to them that we're there to serve them and we're trying to partner with them. And that's certainly what your collaborative is doing. It's how do we get partnerships, and what better way for us to do it than to be transparent? I think it actually enhances our relationships, and I think it makes our jobs easier, and it makes their lives better. So that's certainly my view.
Thanks so much. It's been so helpful to have your guidance, and Steve has been so generous with sharing the resources that are available on the My OpenNotes website. It's really helpful. There's a great toolkit with a lot of example language and articles that are specific to mental health and cancer. Amy and I are happy to stay on for a few minutes, but I just wanted to make sure we took the time Steve for sharing his expertise, and for all of you for coming together. It's wonderful to see so many people interested in improving communication with people affected by cancer and mental illness. So thank you, everyone.
Thank you for having me.